So we are going to start the next session of the Think Under the Apple Tree. And the chairperson for this session is Dr. Satjit Sinha. Sir, please join the session. Dr. Sasi Thorat, sir. I think sir is coming, and myself, Deepak Mishra. Judges, our esteemed judges for this session is Dr. Anand, sir. Anand Panikar, sir. Sir, Anand, sir, please join the stage. Dr. Dinesh Garg, sir. Dr. Mahesh Kumar Somani, sir. Manisha, ma'am. And Dr. Sanjay Kumar Thakur, sir. Please. I think our judges need no introduction, although we made a lot of slides for them. So we go for the rules. Just come to the rules. Yes. All the participants, listen carefully. The presentation timing is 4 minutes, and the mark sheets and the marks will be awarded on that. If you exceed the time, there will be reduction of the marks by the judges. Discussion time is 2 minutes, and all the criteria, all the 5 criteria based on which the marks will be given is already written here. Novelty, 20% practical application, social impact, cost efficiency, and the potential viability of your things. After this, the top 10 will be presented again at the 2:30 p.m. here. Meanwhile, our ARC team and the team will calculate the marks and inform you. So with this rules, I will like to invite the first person. So the first presentation is by, give me the mark sheets. Sajid sir, kindly invite the first presenter for here on the stage.
Thank you, Dr. Deepak. I'd like to call the first speaker, Dr. Prithvi Chandrakant. Dr. Prithvi is here. Yeah. Dr. Prithvi will be speaking on tactile. He is a ratified member of AIOS.
Tactile, a tactile marker for medications to assist patients with low vision. Imagine a blind patient who has been prescribed 3 different eye drops. The biggest challenge? Identifying which drop to use and how many times a day. Now consider other scenarios. A patient with blurry vision who cannot read the label, or someone without assistance to help administer the drops. Studies have documented cases of inadvertent use of non-ophthalmic drops. Studies have documented times a day. Tactile, a tactile marker for medications to assist patients with low vision. Imagine a blind patient who has been prescribed 3 different eye drops. The biggest challenge? Identifying which drop to use and how many times a day. Now consider other scenarios. A patient with blurry vision who cannot read the label, or someone without assistance to help administer the drops. Studies have documented cases of inadvertent use of non-ophthalmic drops, highlighting this as a significant issue. How can we create an affordable, practical solution to help visually impaired patients correctly identify their eye drops and dosage? Our answer to this challenge is Tactile, a simple yet effective tactile marker system. We explored 3 prototypes. Bindi markers, most affordable approach, using Indian bindis, which cost just 10 rupees per set, as tactile markers on eye drop bottles. Embossed label markers, most effective approach. A label embosser, available on Amazon for just 999 rupees. It is used to create raised numeric markers by pressing a lever with the desired alphabet or symbol. The embossed strip is then attached to the eye drop bottle, providing an easy way to identify the correct dosage. 3D printed markers, customizable approach. 3D printing tactile markers and attaching them to eye drop bottles. Different shapes represent different drug categories. A triangle for antibiotics, a plus sign for lubricants, and so on, and it costs 1 rupee for a piece. Evaluating the impact. We conducted a study with two groups. Control group, 150 patients, used eye drops traditionally. Intervention group, 150 patients, used eye drops with a tactile marker. The results? Higher adherence rates, hence fewer missed doses. Increased ease of use, making medication management effortless. Greater confidence in self-administration, hence empowering patients to be more independent. Why tactile matters. Enhanced medication identification, reduced medication errors, improved treatment adherence, increased patient independence, minimized adverse effects. It is cost-effective, scalable solution, improved quality of life, reduced cognitive load on patients, enhanced caregiver efficiency, potential for smart healthcare integration. Conclusion: tactile markers for ophthalmic medications enhance patient safety, reduce medication errors, and promote independence among visually impaired individuals. Ultimately, this leads to better treatment adherence, increased confidence, and improved health outcomes. Tactile, a tactile mark.
Dr. Prithvi, I have a question for you.
Yes.
Why are you using someone else's voiceover? Why not yours?
You have to use your own.
Okay.
No, I want to know your logic behind using someone else's voice. It was a foreign accent.
मेरी presentation का pre-requirement भी है कि आपको अपना part डालना है.
No, but just tell me your logic. I just want to
No,
know your
makes it more clear. That's why.
Means you want to say our accent is not clear, or you
No,
want
not-
to say your voice is not clear?
I'm not talking about the accent. I was talking about the clarity on the voice.
You mean to say your
My-
yours
I
is
don't
not
have a good
clarity? You
recording
don't have
system.
clarity.
Maybe
That
what
means
that
I will not be understanding you now because you don't have clarity by the same logic.
So this
अरे
is
सर,
probably
बच्चे का
some
Wi-Fi ले
AI
लीजिए.
using.
No, my thinking is, was it prepared by someone else, or was it being used somewhere else by someone other also? Because this is a generic now. Anyone can use this in any other forum.
I think usually, sir, you have softwares
I know.
where you have these predetermined voices, but I think it's a very novel idea, and especially we have never thought of patients who are having a low vision.
Yes.
So I think it's a very well thought
Yes, ma'am.
thing that they have a good compliance
Yes,
with the medication
Actually,
that they
this
are
whole
using.
idea came when a patient of mine, retina patient, he came with the he was using homemade secondarily,
Right.
and he was using Predford for BD dose. So when I asked him, he's like, it was very difficult for me to understand which drop to, and this often happens in glaucoma patients also.
Right.
So that is when I came up with an idea, why not do something, some other, sense, that is touch sense, which would be most. Otherwise, you have even the smell and even hear, but then it becomes very expensive. So the most efficient and most frugal way of doing this was through touch. So that is
Very
why
nice.
we came with this kind of an approach.
So
Where,
your clinic usually puts this and then sends out
yes,
the
ma'am.
patient?
All our post-op surgeries, we started using this, and we have found out that the patients have a very good positive feedback. Basically, because they become more independent and they know which drug to put how many times. They don't really have to ask for somebody else also. They just have to touch and they're like, this is 4 times. Can you just put
Very
it?
well thought of. Very well
Yes.
thought of.
Did you search in the literature? Has it been used? I thought that this particular method should have been used for blind people elsewhere, and there may have been reports.
So
I don't dispute that
yes,
yours
sir.
is a good technique,
Yes, sir.
cost effective,
Huh.
simple, and the requirement of this is more even with patients who cannot read the fine print despite having good
True,
vision,
true. In the literature review, what I've done,
especially for blind people.
yes, sir. So in the literature review, there is a provision where they have color coded the eye drops in AAO.
No,
So that
for-
is standardized,
no.
but again, it's not going to help with the dosage or
No,
eye
for
line.
blind people.
For blind people, yes.
For blind people, they make use of the tactile sense, the same thing.
Correct.
But I wanted to know whether this idea has been used by others also, especially for blind people with the help of braille language.
Wonderful,
They're not
wonderful
giving-
presentation.
Thank you.
Just in lighter vein, 2 to 3 times is okay, but post-operative, immediate post-operative, sometimes we say hourly.
Yeah.
How do you mark that?
So again, we have two type of marker over here. One is the line marker, and we have the symbol marker also.
Symbol means hourly.
Symbol means we can tell them it is hourly. We sensitize them priorly while giving the drops.
Okay, we'll call the next speaker.
So do you have any plans to patent this?
Not as because it's something do it yourself, so it becomes easy for everybody to do it actually. In their
So
just
make
have
it
to-
open.
That green embosser comes in the Amazon for 1,000 rupees, so that can be bought by anybody. They can start using. Yes.
We'd like to call the next speaker now, Dr. Anjali Khadia. Dr. Anjali is here, and she'll be speaking on double flange technique in iridodialysis repair. Dr. Anjali is a ratified member of AIOS. Dr. Anjali, please.
Good morning, everyone. So my presentation is double flange technique for iridodialysis repair. I have no financial interest in this presentation. So challenges in iridodialysis repairs, it's require high level of surgical experience and skills, and majority of our ophthalmologists are not trained for performing the conventional iris repair because iris is very thin and delicate and take longer duration. So here you will demonstrate simple, low cost, safe, minimally invasive, that is double flange technique. So main instrument here is the low temperature cautery and 70 Prolene suture. So we describe here two approach, that is ab interno from iris to sclera and ab externo, that is from sclera to iris. So this is the ab interno approach. This is animation come multiple picture. And this is ab interno approach. surgical
Iridodialysis can be seen from 3 to 8 clock hour. A spatulated straight needle with 70 Prolene suture is introduced from the main incision parallel to the iris using needle holding forceps. This exits from the sclera approximately 1.5 mm from the limbus at 6 o'clock position. The proximal suture is cut, then flanged with low temperature cautery and pulled towards 6 o'clock. The distal end is also cut, leaving a stump of 1.5 centimeters. Next, in the same manner, now needle is introduced from 9 o'clock position. The needle is exteriorized at 3 o'clock position. The proximal end is cut, then flanged, gently pulled towards 3 o'clock position, and the distal end is then cut. In the same way, another needle is inserted from 11 o'clock, exteriorized at 5 o'clock, and the same procedure is repeated again. Now, all the three distal ends of the suture are gently pulled and tightened so that the iris appears flat. All the three distal ends are now flanged at the scleral end with the help of low temperature cautery. All the viscoelastic from the anterior chamber is now washed, anterior chamber is formed, and conjunctiva is opposed with the help of bipolar cautery.
This is the ab external approach. So needle is passing a sclera to the iris and then exterize suture using the Kugling hooks and then flanging the proximal end of the suture and then flanging the distal end of the suture. Then after that conjunctival closure. So why we choose double flange technique? Coming to the literature, the Kasaka et al. 2019, they use the 27 gauge needles, pre-flange, and they use the high temperature. But our double flange technique, we no need of any pre-flange, the sutures and extra needle or docking. And 2022, the Rosenband et al. They also use 27 gauge needle with ab interno. But our double flange technique, no need of any needle docking. It can be done both ab internal as well as ab external. Peng et al. 2023, they use 30 gauge needles. Same years, Vivekananda et al. They also use 26 gauge needle, that is ab external approach. They use 60 Prolene suture and suture loop is lying, that is U-shape, lying over the iris surface. But our double flange technique, suture flange is lying over the iris surface and no need of any needle docking and can be done both ab internal as well as ab external. So advantage of our technique is very simple, minimal invasive, quick, subtle learning curve and can be safely done by our all cataract surgeon and can be done both ab internal as well as ab external. So this needle, thank you. So this needle is spatulated 30 centimeter gauge and the force is that is 40 gram. So it is easily enter to the iris as well as the limbus. And compared to the 26 gauge needle and 30 gauge needle, that is we are conventionally use. So it is very and the whatever is flange we are doing, that is very dot like suppose the thickness is it is 100 to 200 microns, and that when we making the flange it is 0.2 to 5, that's very less millimeters. And then but iris thickness, that is 1.2 millimeters millimeter is there, then when we flange is there, no, so it is easily go and very stable also. And during the flanging, that where tightening is there, that should not be too much loose, or should not be too much tight, otherwise more tight that is easily come out. So that SFL we are doing slightly tight, but in the iris repair we slightly take loose, so that it stay flange is this side and outside also, so easily stable.
Good, very good. Any questions?
This will outscore other technique. Means, which type of dialysis do you think it should be really done?
Yes, sir.
Which type of dialysis you think it should be done? Will you do it for just 1 hour?
No, sir.
Clock hour dialysis.
No, any clock hour we can do, any on the right handed also, there is no problem. Left handed, there no need. Right handed, any side.
No, why did I ask you was, this double flange technique will be useful where your dialysis is large.
But here is there is no problem. Ab internal, we describe both ab internal as well as ab external. Suppose it's not possible, then you do the ab internal also, sir.
Any
so that
incidence of rise of intraocular pressure in the post-op period, and did you do goniotomy?
Sir, all patients you have to do the gonioscopy to look any angle closure that is, and take the any our IOP intraocular pressure. So with that, but we did till now 4 patients. All patients are good. Visual acuity is good, and there is IOP also normal, sir. And thank you, sir.
Thank you, Dr. Anjali. That was a wonderful presentation. Now we'll like to call Dr. Parthasarthi Roy. Dr. Parthasarthi is here. He is a ratified member of AIOS, and he'll be speaking on breakdown of natural defense residing in meibomian fats is the cause of seasonal trends of coronavirus infection. Dr.
Hi.
Parthasarthi.
Hi everybody, good morning. I am Dr. Parthasarthi Roy. I'll be talking about my invention breakdown of natural defense residing in meibomian fats is the cause of seasonal trends of coronavirus infection. I have no financial interest to disclose. In India, coronavirus infection had shown seasonal trend. First and second waves both started in winter months. Similar winter trends were also observed worldwide. This led me to search for the cause of this seasonal trend of coronavirus infection. I hypothesized that there is an inbuilt protective mechanism lying within the inbuilt mechanism against coronavirus infection, and breakdown of that protective mechanism in the winter facilitated outbreak of the pandemic. There is a great reserve of fat in the meibomian glands. Base hydrolysis of these fats under appropriate temperature and moisture may produce soap to take care of virus by lysis of its lipid envelope. Besides, commensals like Staph aureus, Staph epidermidis, Propionibacterium acne break down meibomian lipids to free fatty acids, which by neutralization reaction in alkaline tears produce carboxylate ions, which act as soaps. Vestibule of nose gets a good complement of this soap from tears drained from eyes via inferior meatus. Meibomian gland secretion has a melting point of 35 degrees Celsius, and at 15 to 17 degrees Celsius it stops flowing. It is a proven fact that bile salts present in the lumen of small intestine can destroy also lipid envelope of coronavirus, thus restrict its entry through gastrointestinal route. After conjoint reading of all these facts, I developed the following hypothesis: that there is an inbuilt protective mechanism. Visible soap formation in blepharitis is probably due to excessive bacterial lipase activity, but in normal condition there is still invisible soap formation in tears due to lipolytic enzymatic activity of commensal bacteria which can kill coronavirus. In winter months, meibomian flow from meibomian gland is diminished, thus jeopardize the defense mechanism. Therefore, our aim is to see whether flow of meibomian secretion is reduced in November-December month. We thus initiated a pilot study comprises of 8 normal subjects, 3 males and 5 females between 28 to 30 years, and took serial readings of pH, temperature of conjunctival sac and environmental humidity, and compared them to the degree of plugging of meibomian duct orifice and degree of obstruction of meibomian flow. pH of the cul-de-sac remained 8 for all subjects for all seasons. In first 3 seasons, no plugging of duct orifices and blockage of meibum expression was seen in any subjects. In November-December data, 5 out of 8 subjects showed grade 2 plugging of meibomian duct, and these 5 out of these 5 subjects, 4 cases had grade 1 case had grade 2 obstruction of meibomian expression. Therefore, in November-December, due to reduction of environmental humidity and decrease in cul-de-sac temperature, in comparison to other 3 seasons, blockage of meibomian flow occurred. This is the now. Our conclusion is there was obstruction to the meibomian flow, thus serious jeopardization of the protection against coronavirus infection occurred due to the delayed availability of soap forming fat in the tears, making subjects susceptible to infection. Thank you, sir.
Thank you. Any questions, please?
What will be the clinical significance as regards the coronavirus infection is concerned?
Actually, in the worldwide, it is found that in winter it happens, and winter what happens, the meibomian duct are clogged and there is less flow of meibum into the conjunctival sac, so there is.
We agree with your hypothesis. We agree with the hypothesis, and we also find and report, it is reported that the incidence of blepharitis is more in winter. However, 2 things which are striking us is, what is the relation between this and corona, one thing, and second thing, it is all right to report that there will be solidification of the sebum in meibomian gland secretion in countries where the temperature drops down considerably. But from the part of India from where you are hailing and you have done the study, even in the winter, the temperature cannot go below, say.
But whatever the temperature dips down, it has been proved that it has a significant effect on the meibomian gland, so that the secretion is less, and that less secretion causes less soap formation, and so the lipid membrane which has had effect on it.
Why I asked you this question is, whatever temperatures you have reported, they are fine for the western thing, but in our scenario, I have got blepharitis, and I can say 1 month down the line winter is going to set in because the blepharitis sets in. So I agree with you, and now your correlation with corona?
Actually, the blepharitis is a separate entity. I am not talking about the blepharitis.
We are talking about this relation with corona.
The relationship with corona is that in the winter months there is less meibum is available in the conjunctival sac. So there is may not be visible, but in the microscopical level there is soap formation, and that soap is taking care of the coronavirus by lysis of its lipid membrane. But when the winter sets in, all the other seasons this is happening, but in the winter season, as the fat is less this is one of the reasons that these tears go to the vestibule of the nose and is playing a part in the causation of the corona in the winter. And apart from that, as it is beyond my scope, there is this T zone of the face. Here also there is sebum glands. This sebum is secreted and is there so much of sebum in the nasal vestibule. That also take place.
Thank you,
plus
sir.
in the
We'll move on to the next.
prevention.
I'd like to request Anand sir to please give a certificate to Dr. Partha Sarthi, please. I'd like to request Dinesh sir to please give a certificate to Dr. Prithvi Chandrakant. I'd like to request Dr. Manisha Agarwal to please give a certificate to Dr. Anjali Khadia. And I'd like to call the next speaker, Dr. Virangi Doshi. Dr. Virangi is here. She's a ratified member of AIOS and she'll be speaking on ROP, SSTS, retinopathy of prematurity screening, Sankara, skill transfer system. Dr. Virangi, please.
Yeah. Hello everyone. I'm Dr. Virangi Doshi and I shall be presenting our unique do-it-yourself model of ROP Shankara Skill Transfer System. Don't we all remember how scary the idea of screening those tiny souls felt at first? Well, it's an even trickier situation when we have to examine and document good quality photographs with wide-angle fundus cameras which require a good hand-eye-leg coordination, which if not competent with, can lead to undue stress on the child. We know that documenting and screening involves wide-angle fundus cameras which have a probe resting on the eye in one hand, a foot pedal being operated by one leg to capture good images in a jiffy, all the while our eyes and mind dynamically taking note of everything. To ace this sync needs practice, and for this we need simulators. That's when we put our Jugadu minds at work and designed our ROP Shankara Skill Transfer System using a commercially available newborn baby mannequin and the commercially available RETI, thus saving us a large cost. To make our model, we used a newborn baby mannequin available online and cut the rims of the eye for a better exposure. We then secured the RETI from underneath with the help of a hot glue. Printouts of various ROP pathologies can be used as templates and can be molded and secured in the detachable posterior portion of the RETI, as shown in the video. Alternatively, we made use of a mobile screen for a very high definition image, as shown here. To study the effectiveness of this model, we carried out an in-house small experiment with optometrists who were not trained in ROP photography. And we noticed that there was an improved handling time of the machine and decreased screening times. And at the same time, the quality of images captured over time improved. In contrast to other available simulators, which burn a hole in the pocket, can be used either for direct or indirect ophthalmoscopy and can be used only for particular pathologies like diabetic retinopathy. Our model is both cost effective, can be used for both direct and indirect ophthalmoscopy training, and can be used for multiple pathologies. To the best of our knowledge, there is no such model for ROP photography screening training. Considering the design related aspects, the imaging in our model is not wide field, but that is one aspect which is under consideration. Thank you for your patient listening.
Very good, very good. Any questions?
So that's a very nice model you've
Thank you.
created. I just wanted to ask you that when you are placing the camera on that eye, I assume that the eye is having a plastic there.
Correct, yeah.
So do you put any kind of agent in
We
between?
put a viscoelastic over the eye in between the probe and the plastic model.
And the images are captured quite clear?
The images are quite clear. If you would allow me to open it once again.
थोड़ा
sir,
स्क्रीन
just
ऑन
one
कर
minute.
दीजिए, इनका प्रेजेंटेशन ऑन कर दीजिए.
So the images are equivalent to the template which we use. So the template printout, if it has some pixelations, the images are such. But like I said, we also use the mobile screen for a better quality image. So in the same way, the images which we see on the laptop are also equally good. I'll just show you.
Yes.
I wish you could have shown us the pictures first before undergoing this training through the simulator,
Right.
and then after that.
Right.
And grading those images on issues like clarity and details.
Yeah. Sir, that's what the self-assessment questionnaire. We had a couple of parameters for the optometrists who are undergoing the training. So we had 4 parameters like sharpness of the image, the graph of which I've placed in the presentation. One was sharpness, one was the artifacts, one was the pixelations, and one was the percentage of image they could capture in the photograph. So on the basis of that, we had standardized templates, and they had graded themselves. Just for an example, I've just placed the sharpness of the images here, but otherwise they had improved overall.
That is what we were saying. That
Right.
If you could have demonstrated that there was a significant, it is expected.
Yes, yes.
It is
I
expected.
For
understand,
paucity of
sir.
time, we'll have to move forward.
Kind of
Thank you.
pre and post
I'd like
test
to
you
request
can do.
Sanjay sir to please
How
give
many optometrists have you
certificate to
trained till
Dr.
now?
Virangi
We had
Doshi.
trained approximately 8 to 10 optometrists, 2 of which had to be transferred during the training, but they underwent approximately 8 to 10 sessions of training.
Thanks.
Thank you.
Can I call Dr. Ghulam Ali Kamdar? Dr. Ghulam Ali Kamdar.
Please, you can take a seat.
Dr. Virangi, please.
Welcome to a journey of experience.
Dr. Ghulam sir is not there.
Yeah, sir, sir is not there. We have taken actually permission. I'm presenting on the behalf of Dr. Ghulam Ali Kamdar, sir.
You have taken permission of the scientific committee?
Yes, sir.
Okay, thank you. So, what is your name,
Dr.
please?
Rajshri Hirawat.
Dr. Rashi will be speaking on restoring vision with scleral fixation of toric IOL in complex trauma cases. Dr. Rashi, please.
Exploring an innovative solution for ocular trauma, suture fixation of toric IOL for visual rehabilitation. Managing ocular trauma is complex with challenges in assessment, inflammation, prosthesis choice. Today we present 2 cases and a novel visual rehabilitation solution. A 51-year-old male underwent corneal tear repair, subsequent retinal detachment surgery. Post-silicon oil removal, vision improved to 612 but 6.52 diopter astigmatism, traumatic mydriasis and aphakia hindered further visual rehabilitation. Though options for rigid gas permeable lenses and SFR were there, we wanted a solution that could provide spectacle corrected vision while addressing other challenges simultaneously. Enter our novel approach. Instead of conventional capsular bag implantation, we choose suture fixation of toric IOL with residual astigmatism of 1.99 diopter. Pre-operative slit lamp and intraoperative toric axis marking were done. Limited conjunctival opening were made at 3 and 9 o'clock with careful cauterization. 2 3x3 mm scleral flaps were created at the toric axis and SNQ scleral tunnel was repaired for IOL insertion. A tenopropylene suture was passed 1.5 mm from the limbus, docked into a 26 gauge needle and repeated for the second needle. The sutures were extracted, cut and tied at the optic haptic junction in a 3-to-1 fashion. The IOL was positioned by pulling the sutures under the scleral flap, followed by a careful titration and toric axis alignment. Finally, a single pass 4-throw pupilloplasty was performed to correct traumatic mydriasis and optimize pupil size. 2-week post-op, vision improved to 6/18. 30-month follow-up, the vision was 6/9 with 1.52 residual astigmatism. UBM confirmed centered toric IOL with no tilt. Our second case was a 21-year-old male with post-traumatic corneal fibrovascular scar, cataract and eccentric pupil. Previous record showed BCB of 6.9 with -4 diopter cylinder. Online toric power calculator showed residual astigmatism of 0.067 diopter. Pre-operative slit lamp and intraoperative toric axis marking were completed. Phacoemulsification with in-the-bag toric IOL implantation was planned initially, but a calcified cataract tightly adhered in one quadrant required a pars plana approach for extraction. Two 3 into 3 mm partial thickness scleral flaps were created on the toric axis. A clear corneal tunnel was prepared for IOL insertion, and a 4-point horizontal fixation was done using Gore-Tex sutures past 3 mm from the limbus. The sutures were looped into the junction of optic and haptic of the toric IOL, and after careful titration, final tying and toric axis alignment were confirmed. The 7-month follow-up showed well-centered toric IOL, uncorrected visual acuity 6/12 and best corrected visual acuity 6.9 with -0.5 diopter sphere. Conventionally, toric IOL are implanted in the capsular bag. Our innovative approach of suture fixation is proving to be a game changer. These cases, unique to the Indian scenario, showcase the potential of this technique in addressing significant astigmatism with no capsular support. Management after ocular trauma indeed be challenging due to the complex nature of injuries and the delicate anatomy of the eye. Each of these challenges require a tailored approach integrating surgical expertise, careful postoperative management, and a long-term rehabilitation plan. Collaboration among ophthalmologists and optometrists is often necessary to optimize the outcome.
Thank you, Dr. Rashi. For paucity of time, we'll just take one question because the main presenter is not here. Sir, any question you want to ask?
You reported very good results, but I was a little skeptical because this astigmatism is a little unstable in such cases and it takes a long time to recover.
Yes, sir.
But I would go with whatever you.
Yeah, sir. Actually, we have performed surgery. As you said, we have waited for 1 year after silicone oil removal. When the refraction was stable, then only we planned it. Because
but I think we need to understand in these post-trauma cases, it is basically the curvature of the cornea which has changed because of the corneal tear. So it's more the corneal astigmatism that we are dealing with, and often these patients would require an RGP contact lens to overcome that. So I was wondering that how much that can be overcome by putting in a toric IOL.
So, initially we planned for the RGP only. With RGP, patient was improving 6/12. So that's why we thought patient has a visual acuity. Why not we should take a chance while doing this kind of surgery? And this first patient has finished 3 years follow-up till now. So residual refraction is stable, and everything is stable. Patient is maintaining good vision. There is no tilt. And the second patient also have completed 1 year follow-up.
Thank you.
Can I request Dr. Anand sir to please give the certificate to Dr. Rashi? I'd like to invite the next speaker, Dr. Pranshu Goyal. He's a ratified member of AIOS and he'll be speaking on low-cost practice module for vitrectomy and intravitreal injections. Dr. Pranshu Goyal, please.
Good morning, everyone. At the outset, I would like to thank AIOS Scientific Committee for giving me this opportunity. I'll be presenting on low-cost practice modules for vitrectomy and intravitreal injections. It is not going forward.
That side probably you have to present from there.
इनका देखिए आगे नहीं बढ़ रहा है.
Yeah, no financial interest. As rightly said by Kevin Durant, the more you sweat in practice, the less you bleed in battle. Before any game, we need practice. So why not the case with VR surgery? So there are few available VR simulators available like IC from Hackstree, which costs up to rupees 1 CR or more. So why not we come up with a less expensive and more accessible one? So we have come up with an innovative module for injection and VR surgery practice, costing between rupees 300 to rupees 2000. Coming to injection module, here we have just used a double-sided tape and a small plastic container attaching tape to it, and practicing giving intravitreal injections with right hand and left hand individually, around 50 to 100 times before giving it in a real patient. So we have taken a small ping pong ball and using a commercially available eye model and attaching the eyeball from behind using a double-sided tape and practicing it with this with right hand left hand to give a more realistic feel. So this is me giving intravitreal injection in my first month of fellowship with my left hand in a very smooth, controlled fashion with good hand stability, single-handedly, in a phakic patient. Coming to retina practice module, so we have taken the similar eye model and a smaller ball available at any toy store and attached with a double-sided tape from behind. And we have used a suction machine available in OT and portable light source with magnifying lens. As visitors substitutes, expired lubricating drops can be used or removed silicone oil from SOR. So attaching the suction machine to an old used cutter via nasogastric tube, stellate of an IV cannula can also be used, which have to be cut from here. So this is our whole setup. So this is me training and this is the trainee's view. So this is me practicing fluid air exchange outside the OT. So this can be done inside the OT also. So this is a laser practice film available commercially. So on the left hand side, this is me before practice with a very poor focus and poor hand coordination and direction. And on the right hand side, a very drastically improved focus and hand coordination and direction. Coming to vitrectomy, on left hand side, we have used colored sugar syrup to mimic vitreous hemorrhage. And on the right hand side, post practice, this is me doing vitrectomy in a case of vitreous hemorrhage. Coming to ILM peeling, so using the same laser practice film and using the inner side of the onion peel and sticking it to the film with the use of a fevistick and staining it with commercially available blue colored fabric whitener solution, or even colored contact lens can also be used. So this is me practicing ILM peeling in OT under the microscope. And post practice, this is me performing ILM peeling in a case of traumatic macular hole. So these are my graphs which has shown improvement on the basis of hand stability, technique, precision, dexterity and speed on a scale of 1 to 10 assessed by an assessor in a 4-week period. So our model is made from easily available materials at a very low cost and can be practiced anywhere, especially out of OT, not dependent on VR machine, giving good hands-on experience. Some limitations is it is based on single doctor's assessment and based on line chart, and statistical analysis could not be performed. So at the end, I would like to thank my mentor and my staff.
Thank you very much. Please ask a question.
You have told us about your experience after.
Yes.
I wish we could have used it in some more residents and shared their feedback.
Yes, sir, that's my future plan, as I have shown that I would like
हो गया,
the
मत
state
on करो, हो गया.
societies, but it has shown very drastic improvement.
Very innovative, yes.
Thank you so much.
Can we call Dr. Bhumi? I would like to request Dr. Dinesh Garg sir to please give a certificate to Dr. Pranshu Goyal. We'd like to invite Dr. Bhumi Chandrana. Is she there? So judges, please note Dr. Bhumi is absent. Next, Dr. Shruti Nishant. Dr. Shruti is here. Dr. Shruti is a ratified member of the AIOS and she'll be speaking on comparative study of conventional eye drops versus novel vaporized spray of cycloplegic mediatric protocol in Indian pediatric cohort. Dr. Shruti, please.
Good morning, everyone. I'm Dr. Shruti Nishant, and I'm a pediatric ophthalmologist. And being one, I think it's a great joy to actually look at the children's eyes. But there's a big problem that we face in and day out, and that's the fear of the eye drop in the clinic. And this eye drop issue is something all of us face because children do have pre-drop anxiety. They have poor cooperation because of that, prolonged dilatation time, difficult patient-doctor relationships, and also difficulty in post-op follow-up periods because of the specific anxiety. And there is a paper that talks about the psychological impact of eye drops administration, where children can be cooperative up to 45% of the time. So this is a serious issue. In order to solve this problem, we have come up with a novel solution of a spray delivery of the cycloplegic and midriatic drug in a bottle format. Now, this is done using a glass bottle of 15 ml that we sourced from Amazon with a medical grade plastic spray nozzle that can be easily attached in an airtight format. The drug that we used is actually the dilating drops that we normally use in our clinic. However, in a clean environment, after the ETO of the bottles and the nozzle, we take out the medicine from the bottle and then inject it into the glass bottle and then close it with the airtight nozzle. So here you can see me filling it up and using the bottle. So in order to check this out, we did a pilot study to compare the conventional eye drop versus this vaporized spray using the CTC protocol, and we wanted to do it in 3 ways. One is to compare the mydriatic effect, to compare the cycloplegic effect, and also to compare the objective and the subjective response of the child. So after ethics committee approval, we recruited 13 children with a mean age of 8 years. One eye went into control, so the child was put on drops, and the other eye was randomized to the study, which was the spray. Here you can see the spray being applied. The spray was applied 5 minutes at 5 minutes interval. The parameters that we looked at was mydriasis, cycloplegic effect, the objective response, the subjective response, and the adverse events. We looked at pupil measurements, MEM retinoscopy, Wong-Baker pain scale, and questionnaires for the other 2 parts. Now, the results, when we looked at the mydriasis effect, what we saw was a really good response. The red line that you see is the drop, and the blue line that you see is the spray, and you can see there's a really no statistically significant difference between the 2 methods, and both the methods achieved equal, if not same results. And when we looked at the absolute mean difference in pupil size, the spray got about 4.8 mm of dilatation, and it was interesting to note the 15-minute to 40-minute was the best effect. The cycloplegic effect as well after MEM retinoscopy showed similar levels of cycloplegia in both the groups. There was no statistical significance. When we looked at the Wong-Baker pain rating scale, that's where we saw the difference. The score in the spray group was 0.7 versus the drops group, which was 5.38. When we looked at we made a 24-hour phone call to the parents after the drop, and we saw that beyond the regular blurry vision photophobia complaints, there was no adverse events. And when we asked the children for what they preferred, 100% of the children wanted to prefer the spray. Now, one question that arises is how does the spray work? It is working through the transconjunctival mechanism, through the closed eyelids, through the pupils. And we also went ahead and did a volume check of how much volume is being sprayed. This is thanks to Dr. Sivanyanam here. We did it at IIT Madras, and we saw that both the spray and the drop had comparable volumes to spray. And we also looked at the area, how much of spray is spread is there, and then we saw that it was 3 mm width and 5 centimeter height, which is within the brow line, so that's also done. So to conclude this, the spray method of delivery is safe, it's effective, and it's better tolerated than the eye drop. And how it translates into clinical practice is lesser anxiety for the patient and the doctor, faster OPD visit, and of course it can be used in multiple areas also, like special children and elderly adults. Thank you.
Thank you, Dr. Shruti. One question. Judges, do you want to ask one question?
You mean to say the ordinary eye drop solution can be converted into a spray so that it can be sprayed by just putting it in a bottle?
Yes, sir. So here we just tried it out because it was a pilot study, and ethical clearance gave us only for 15 patients maximum. So we did it de novo on our own, but we are now talking with pharma companies to see whether we can bring it as a
there
spray
are
format.
one or two issues in it. This vapor business is being explored as a method of delivery of the drugs in eye. The problem is to have a vehicle which will convert it into vapor at ordinary room temperature. Unless you have a vehicle which will take it there, it is not possible. And then whether the vapors can penetrate the current ocular surface barriers for penetration.
Using it through skin.
Yes, it's on closed eyelids, but the mechanism which we are proposing is through the transconjunctival route, because the stinging is lesser, but still it goes into the conjunctival region.
Skin, and then the side effects will be more. If you note, whenever you put atropine drops in a child, the first thing that you tell the parents is to put pressure on the medial
Sir,
canthus.
for paucity of time, we'll have to move on. I'd like to request Dr. Manisha Agarwal to please give a certificate to Dr. Shruti. May I request Dr. Anju Kureskos. Dr. Anju is a ratified member of AIOS, and she'll be speaking on UVOscope, a smart app for investigating and diagnosing uveitis. Dr. Anju, please.
Thank you, sir. Good morning, everyone. Thank you for this opportunity. Today, I am excited to introduce UVOscope, a mobile application designed by uveitis specialists to assist doctors in diagnosing uveitis and recommending appropriate ancillary investigations and blood investigations. Let's start with a small story of a 35-year-old Mr. Kumar.
Good morning. What brings you here?
I am having eye pain and redness since few days.
Looks like you have uveitis. You will need some blood investigations.
Doctor, all my blood tests are normal.
Looks like you will need more tests.
My vision is more blurry now.
Don't worry. We will do more tests to find out what your actual problem is.
I am going blind. All my test reports are normal.
So
Good
this
morning.
is a story.
What brings you here?
So this is a story I see often in my clinic. It inspired me to create a uveoscope. We all know Kumar's story is not a unique story. Uveitis is a leading cause of preventable blindness. Diagnosis is complex with 30 plus causes requiring multidisciplinary approach. Doctors face delays and treatment is delayed. So introducing uveoscope as a mobile application designed to bridge this gap by helping doctors to make informed decisions, ensuring a precise and efficient diagnostic pathway. So now let's see how this works. This is a working model we created. It's freely available in the App Store. First, we will enter the demographic details of the patient. This is one random patient. And enter the symptoms, which includes only the uveitic symptoms. Next, we can include the past history if it is available and required past histories, and we get a summary of the history. And next we go into the examination, in which we will enter the vision, IOP and anterior segment examination, whichever is positive. Focusing only on the uveitic examination findings. Posterior segment also similarly. So this will give a final summary of history and examination with a probable diagnosis with recommended ancillary test and a routine blood investigation which is needed. So why should we use this uveoscope? The key features are, it is expert driven algorithm developed by a uveitis specialist. It is user-friendly interface, is easy and simple navigation. Comprehensive investigation guide which recommends relevant blood investigations and imaging. Evidence-based approach ensures clinical accuracy and reliability. Next is time saving, helps doctors to streamline the diagnostic process. So who can be benefited by this? General ophthalmologists who don't have an access to the uveitis specialist, and residents and fellows, and physicians and rheumatologists who wants to get to know more about the uveitis in detail. So what is the advantage over the traditional method? Traditional method requires extensive experiences and access to multiple guidelines, and this uveoscope is instant evidence-based recommendation at the point of care. So future development is, I would like to do it with the EMR integration and multilingual support for global accessibility. Uveoscope is more than an app, it is a powerful tool designed to empower us to fight against uveitis. So thank you.
Thank you. Any questions, sir?
I appreciate you are saying that it is more than an app, but I am still not convinced with it, because I thought that it was a methodical way of just entering your data and coming out, a little bit of software going into to give you a probable diagnosis, but not more than that. However, I appreciate.
So thing is that what happens is we give more investigations and patient face delays, and patient is coming with the occlusio pupilla and occlusio
Left to
pupilla.
myself, I would have marketed it like that there are so many things, and this makes it easier to pinpoint from amongst this.
Just one thing, it was a nice, what you say, effort, but you said it was an algorithm driven.
We feed the data.
No. When you are feeding the data, it's all right. But if you are creating tests, suggested investigations, that is based on an algorithm, you said. It was written in your slide.
Yeah, it is like.
So who created this algorithm? Is it AI or
no,
you?
we create.
So how did you create that algorithm?
Like we have this acute anterior uveitis have this all this common features, and if it is for acute anterior uveitis, we don't do any recommended ancillary test. So, but in so many places, first of all, when we see uveitis, we will go for OCT, macula, FFA. We'll have to see whether it's needed or not. All this can be recommended.
I just want to congratulate you because it's going to give a basic workup for any uveitis patient. So that's very well appreciated.
Thank you so much, ma'am.
Can I request Dr. Manisha Agarwal to please give a certificate to Dr. Anju Kuryakos? We'd like to call the last speaker for today, Dr. Nikhila Meenakshi Angam. Dr. Meenakshi is there? You are presenting on our behalf? Okay, go ahead. You have taken permission from the scientific committee?
Yes, sir.
Okay, good. What is your name, please?
Chaitanya Aravind Ankam, sir.
Please? Sorry, ARC committee.
Yes, this one.
Take it.
Yes, sir.
Dr. Nikhila is not there, so her colleague will be speaking. A novel device for an effortless, reliable, stress-free rexis in intumescent cataracts.
So my name is Dr. Chaitanya
Dr.
Aravind
Chaitanya.
Ankam. So the current challenges with intumescent cataracts is achieving a well-controlled capsular rexis, and novice surgeons are particularly prone to complications. Existing solutions are either expensive or require extensive experience. So we devised a simple, cost-effective device. So what is the need of this thing is like it's very cost-effective and easy to use, provides controlled decompression, works with any standard phaco machine, and helps in creating a well-formed rexis. It is repeatable and reliable for novice surgeons. The concept and design is it's around to harness the phacofluidics for controlled decompression. And materials used are reusable or single-use cassette tubings and a 23-gauge needle in the phaco machine which we use regularly. So this is a step-by-step approach. So the cut end connectors of the two irrigation lines are cut and they are reversely connected as shown in the image. And then this can be done by a single-use tubing, or you can use it with a multiple use cassettes where you can sterilize along with your instruments. And then the one end is connected to the 23-gauge needle, and the other end is connected to the aspiration line of the phaco machine. And you put the machine in IA mode or a visco mode, and then you just go with the 23-gauge needle with the bevel down in the center of the capsule, and then directly puncture the capsule. In one go you can press the whole foot pedal and then directly aspirate whatever is loose cortex without doing any transverse motion, and just go from the other side port with the same thing, and you can do the same thing again. The IA mode is parameters are 60 to 70% of the maximum value are set. So here the same. So we repeat the process on the either sides, and we complete the capsular rexis once the decompression is done with a Uttarata forceps, and then you get a perfectly well-centered rexis. So we run a small study with we have only 2 surgeons in our center, so it's just a 40-case study. So our outcomes are based on capsular rexis success rate, incidence of rexis runaway, complication rates, and surgical time and efficiency, and the surgeon stress index with the help of a small questionnaire. It's called state rate anxiety inventory. And then 35 of the cases had well-centered adequate sized rexis. Minor complications were faced because of using the routine cystotome rather than the Uttarata forceps, which might have made little more comfortable. So the current available techniques are needle decompression, femtosecond laser, 2-stage capsular rexis, and the needle decompression is very cost effective. Ease of use is moderate, but it requires a little more skillness. And then femtosecond laser, it's a very difficult thing to use it, and at the same time it's very expensive. So the last one, what we have designed is cost effective, very easy, readily available with any new surgeon. And the clinical implication for training program helps to improve confidence in handling instruments in cataracts, cost conscious settings, and for patient safety. Surgeon stress index is lower compared to routine things, and surgical time is also much shorter when you compared to the femtosecond laser and all those things. This can be manufactured even in a titanium metal for more durability and regular usage. So the novel connected device offers a safe, effective, and user-friendly solution for performing capsulorhexis in intimal cataracts. Particularly benefits novice surgeons. Here's a small video demonstration of how we do it. So we just fill it with visco and then directly puncture it and aspirate it with the 60 or 70% of the flow rate from either sides.
Can you move it forward, please,
Yes,
fast?
sir.
Because
Yes, sir. So again, the same different scenario.
thank you. Any questions at this?
First of all, I sort of don't agree with your title because this is just an aid for doing capsulorhexis, first thing. Second thing, you have just addressed one issue, and that is decompression of the increased intralenticular pressure. Third thing is, when you make an opening with any beveled needle, it is those two edges which are likely to result in an Argentinian flag sign. So unless you make a round opening in one stroke, this possibility of it converting into an Argentinian flag sign is not ruled out, which is the major danger in making a CCC in an intumescent cataract. Now the question is, why did you succeed? My simple explanation is that in all these cases, the intralenticular pressure must not have been so high. So I feel that instead of labeling it as a CCC device, you should have said that.
I'd like to request Anand sir to please give a certificate to Dr. Nigru. In the meanwhile, may I request all speakers to please come in up front for a picture, and I'll request all the judges. I'd like to invite Dr. Srinivas Joshi, ARC South, to please join us for the picture over here. And I'd like to request him to please give certificates to the chairpersons and the judges. And I'd like to request Dr. Santosh Bide sir to please join us in the front, and Dr. Mohan Rajan sir, please join us in the front.
Thank you, Dr. Satyajit, and all the judges, Dr. Manisha madam.
That's why my punchorhexis works very well. When you go and punch, immediately decompress both the front and the back. In your this thing, whatever you're doing, it takes care of only of the first component. The second component is not doing anything because the nucleus is still bulky. Because you're doing in punchorhexis, you're doing phaco, it pushes the nucleus back. So here it will work about 50 to 60% of the time, but not 100% or 90%.
Dr. Srinivas, please give the certificate.
First, we'll have a group photograph. Everybody is asking for it. Madam, come. Our Honorable Secretary VRSI, Dr. Manisha Agarwal,